I want to try and see if I can make you think a little bit differently about a problem that perhaps you believe that you've thought about quite a bit, but hopefully try and convince you that there may be some additional things to consider. To start, we know that smoking is the largest preventable risk factor associated with the development of cancer. Several different cancers, this has been well known. There's about 7,000 compounds in cigarette smoke. Actually, there's 65 known carcinogens. And there's a lot of stuff that's been added to try and increase addiction, specifically to try and increase absorption, addiction, flavoring, and so forth. The Surgeon General's report was the first one to actually try and evaluate what were the effects of tobacco use on cancer treatment outcomes. The conclusions that came out were striking. The evidence was sufficient to demonstrate that smoking by cancer patients and survivors caused adverse outcomes. It specifically increased overall mortality and cancer-related mortality. It increased the risk of getting a second primary cancer, and there were very strong associations between smoking and cancer treatment toxicity. The magnitude of these effects was substantial. If you take a look here, this is actually kind of a summary of the median effects of smoking, positive and negative studies across all cancer disease sites and treatments. With regards to overall mortality, current smoking increased the risk across disease sites and treatments by about 51%. Cancer-related mortality, 61%. And you can see former smoking, quitting smoking in the past, those risks were substantially reduced or non-significant whatsoever. So current smoking was strongly associated with adverse outcomes. And you might think to yourself, well, this is a head, neck, or a lung cancer problem. Well, if you go through and you try and actually identify the studies that have looked across a spectrum of cancers, this actually is a bar graph to kind of give you an idea based on, and the red actually shows, hopefully those of you who are red-green colorblind, the ones on the left. The red bars indicate the number of studies that showed significant negative associations between tobacco use and at least one outcome, survival, toxicity, recurrence, whatever it may be. You can see across head, neck, lung, breast, prostate, hematologic, GU, GI. This isn't a head, neck, and lung cancer problem. This is a cancer problem. The effects are true across disease sites and treatments, and so you can really use this as a way to try and address a variable that's important within reason pretty much across cancer as a whole. The biologic effects of tobacco lead, obviously, to developing cancer. If you think that once you get cancer, it turns off the effects of tobacco, I'm going to argue that you're probably wrong. But unfortunately, we have not done a good job of identifying the biologic effects of tobacco and how we might be able to use this to improve our cancer treatment approaches. We reviewed this a few years ago and found about 34 studies that actually looked at the effects of tobacco in cancer cells. So we started playing with this for a while. And this is all unpublished data. We've been developing this model for several years and actually working on biologic outcomes. So you want to talk about current, recent data. This is as current as it will get. And the entire audience, I just want you to focus on those two circles in the middle bottom of the page. Don't worry about the rest. In biologic systems, smoking, chronic cigarette smoke exposure decreases the effectiveness of radiation, chemotherapy, 5 different chemotherapeutic agents, 8 different cancer cell lines very consistently. And if you want to know the significance, those two circles at the bottom are called clonogenic survival or colony survival assays. And what it is that you grow cells up and then you stain them purple, and the purple cells are the ones that are still left. And you can see there at the bottom, the radiation is the circle on the top. There's not that many cells left when we treat them with radiation. But when I add cigarette smoke to radiation, the one below that is the effect. Can you see a difference? Is this what we're doing if we're treating people with radiation and they're smoking? Do we leave this behind? This is the kind of question you need to ask yourself. And remember, do I want to leave this behind if I'm going to treat someone with radiation and chemotherapy? There's a group of us, again, you're talking about new evidence. This isn't published yet either. There's a group of us who have been working on the cost implications of failure of first-line cancer treatment in patients who smoke. And this basically shows attributable failures per 1,000 patients based on the prevalence of smoking, the baseline failure rates, risk ratios for the effects of cigarette smoke. And the long and short of it is that in the United States, we have 1.6 million cancer patients diagnosed every year. If we have a baseline failure rate of 30%, which is conservative, and we have a smoking risk that's 1.6 or 60%, which came out of the Surgeon General's report, which again is conservative. That's cancer-related mortality. First-line therapy failure is going to be higher than that. If that's the case, if you look, and again, this is new as could be, the cost of treatment being $10, $50, $100, $250,000 for the cost if you fail first-line therapy, Here you can see those two red numbers at $50,000 and $100,000, which is exceptionally justifiable in the United States. We have $1.7 to $3.4 billion a year in cost associated with treating first-line cancer treatment failure because of smoking. Now, I was on a plane, not sleeping as well as I could, but I did spend time trying to figure out what the implications were here in New South Wales. Using the same modeling, if you have $10,000 per treatment failure, it's about $8 million of cost. If it's $50,000, which is I think probably where it is, although I couldn't really get that information, you're talking about $40 million of additional costs. These are from conservative estimates of just first-line treatment failure, not including overall mortality, toxicity, hospitalizations, and so forth. This needs to be updated, but I want you to realize that when you think about tobacco in cancer patients, you've got the biologic effects, the clinical effects, tobacco cessation. I used to have population, but really tobacco cessation-related things. And then we are being pushed more and more into the cost variables associated with this. The facets associated with tobacco use in cancer patients are significant. Don't just think of it as smoking, they don't care, we're not going to provide cessation support. Right now, this is possibly one of the best opportunities we have to improve cancer treatment as a whole. It's difficult to comprehend how insane some people can be, especially when you're insane. I agree. We're not training people as well. We're not thinking about this the same way. We're not getting our residents or medical students thinking the same way. We've got to think a little different. And I hope you walk out of today thinking just a little different, thinking this is something that we need to do and this is something that's important. This slide will never go away. I try to, my favorite thing is that top left, statistics show that teen pregnancy drops off significantly after age 25. Yeah, I agree. I don't need to know anything about that study. It's 100% right? Sometimes the question in front of us is very, very straightforward and obvious. This is one of them. Tobacco doesn't stop at a cancer diagnosis. It continues after. The question is, what can we do to address this to improve our therapeutic outcomes for cancer patients? And this is my talk for the day. I think I can take questions. Is that right?
All right. How can we overcome this notion that smoking cessation interventions are someone else's job?
So I'm a radiation oncologist, and what I do for patients is I try and treat with radiation to help something better, help them live longer, decrease the chance of tumor coming back, help them feel better. Maybe they don't have pain, maybe open an airway, stop bleeding, I don't know, different types of things. And what it comes down to is that in my career, I'm going to see maybe 5,000 patients, and in reality, I'm probably really going to benefit about 2,500, somewhere between 2,000 and 3,000 if I'm pretty effective. We're a radiation oncologist. There's a concept, and actually medical oncology, surgery, so forth. I didn't ask how many people here were physicians. You don't have to raise your hand.
Well, let's do it. Hand up if you're a doctor, just to get a sense. Thank you. So some. Right. Thank you. Welcome.
So this actually may be good. There's something called number needed to treat. How many people do you have to treat to improve one? In the 90s, there was chemotherapy for breast cancer, CMF, this old chemotherapy, been around a long time. It was effective. It did a good job. But AC chemotherapy, which is part of what we do now, it switched. Our entire paradigm shifted to using chemotherapy of a different type, really because there was about a 3 to 4% improvement in overall survival at 8 years. I mean, we focused on 4%. What that means is that the shifting of our care from CMF to AC, one chemotherapy to another, was because if we treated 25 patients, we were going to make one more better. That's number needed to treat. We shifted our entire care paradigm based on we treat 25 patients and we improve one. Smoking, when you look, we're not done with this yet, okay? But I can tell you the range. When you look at the number needed to treat, the lower the number, the better. For a radiation oncologist, in general, a good rule of thumb is that you need a number needed to treat of about 10. Might be 15, but in reality, if you're not going to get a 10% benefit, it's hard to justify the toxicity. For smoking, for survival, recurrence, toxicity, your number needed to treat is between probably 3 and 5. It's probably no higher than 5. Might be a little lower than 3, but you're living at 3 to 5. This is the implications. Let's just go with 5. If you have 5 people that smoke that you didn't get them to quit, You just caused one of those 5 to die, recur, or have toxicity. It's your decision. That's what you're going to see when you don't get someone to quit. The number needed to treat for smoking is astounding. And in this case, I told you earlier I give nicotine replacement when the cows come home. I can do other things and sleep well at night. I can't sleep well at night knowing that every 5 people that smoke, I just left them alone, didn't do anything. Because I know, we have the evidence, we have the data, without a doubt, die, recur, toxicity. At about every 3 to 5 patients, you don't get them to quit, that's what's going to happen to one of them. So the impetus, the motivation for trying to exert this change, decide for yourselves. Is that what you want to hang your hat on when you go home at night? These are the actual, we talk about cost, we talk about phone or in person or nicotine or e-cigarettes or all these other things. This comes down to number needed to treat. Decide if that's what you want to think about when you go to bed at night. Did I miss and cause one of those 5 people to die, recur, have toxicity? That's the reality of where we live with it.